We are at the prime part of the show. This is the good Jerry Springer question to the panel. I like that. This is why we're all here. That is the Silicon Valley Boomer Venture Summit Business Plan Competition. That's the name of the conference, and this is the time when we do the competition. So this is how it's going to work. I'd like to call attention that we have a little bit of a change in our judging crew. Where Ingrid is joining us. Lynn had to make another commitment, so we're welcoming Ingrid to participating. So there's 6 companies in this little sweaty room right behind this door, and they've been practicing their pitches for weeks now. They're very excited. They have 5 minutes to convince this esteemed panel of judges, and we all just heard what their investment priorities are for the short term. They're here to convince them things about their defensibility of their intellectual property, their go-to-market plan, how they're different than their competition, how they're going to provide an awesome exit to their investors at some point. So they have 5 minutes to do that. The judges will have 5 minutes to respond while they're taking notes, while they're pitching. After we get through the 6 companies, we're going to sequester the judges in another quiet, windowless room so they can choose who the winner, who will receive $10,000 in a check that they can really use to ramp up their business. So this is a very exciting time. I am here to keep the trains on time, so to speak. I'm a merciless timekeeper. I will jump on someone if they try to go over their 5 minutes on both sides of the table. So pay attention, you guys as well. And we're going to get out of here. 6 companies is a bit, and there's going to be some changeover. What I'd like to say, too, is this is a very difficult thing to do. I don't know how many entrepreneurs do we have there in the audience right now? And how many of you have participated in pitch day competitions? Oh, a lot of you. So you guys know how difficult and nerve-wracking this is. You guys all know that you're wondering if the clicker will actually work, if the guy up in the booth will change the slide deck on the right time. I had never done that. I still haven't done that, and I don't want to do that. So should something go wrong, let's give support to our folks while they're in that moment of crisis when the sweat starts happening. Maybe cheer them on a bit, and we're going to have a great time. So with all that being said, I'd like to call it our first finalist, which is Noctric Health.
Ladies and gentlemen, very good afternoon to all of you. My name is Sri Ram, and I'm co-founder of Noctric Health. We are an early-stage medical device company spun out of Stanford's Biodesign Fellowship. I'm here to tell you guys a story today. Mrs. Smith is at her doctor's office, and she can't go to sleep. She feels exhausted, frustrated during the day. She can't concentrate, and more importantly, she has this tingling, irritating feeling down her legs that prevents her from falling asleep. Together with her physician, they diagnosed that she's got what's known as restless leg syndrome, or RLS for short. So her first line therapy that she gets into is a dopamine agonist, such as roperidol or pramipexole, which turns out works very well for her. Her symptoms go away, except in less than a year, they're back. They're no longer her legs, and they're no longer at night. And her physician tells her that this is perfectly normal. She's undergone augmentation and puts her on gabapentins. And unfortunately, a vast majority of these patients end up on sleep meds, benzodiazepines and opiates for the rest of their life to help go to sleep. The quality of life of someone in Mrs. Smith's shoes is comparable to someone living with type 2 diabetes or depression. Turns out she's not alone. Over 25 million US adults are symptomatic and have the exact same problem, with over 14 million of them with symptoms that present more than once a week, and 8 million of them considered severe with symptoms presenting more than 2 times a week. And they're faced with this grim reality of living with sleep meds for the rest of their life. At Noctric Health, we believe that this presents a significant opportunity to both impact their quality of lives and come up with a therapeutic solution that works as good as benzodiazepines and dopamine agonists while being more tolerable. When a person with RLS is at sleep, the circulation in their periphery is affected, and it's directly related to their comfort level. So as the circulation in your legs cuts out, they feel these urge to kick their legs and move, and unfortunately this happens multiple times before they fall asleep to where they can't fall asleep. Turns out research agrees with us. Patients that have RLS have significantly decreased circulation in their periphery as opposed to healthy controls. The Noctrix pulsar therapy tees off of this clinical insight. So we monitor the urge symptoms coming on with a wearable anklet on the foot, and then most importantly, act on this impulse by activating the proprioceptors in your feet. What this does is tricks your brain into thinking you're moving your feet when there's actually no physical movement. And finally, we prevent the symptoms of this urge from recurring by restoring peripheral vascular circulation. So if we go back to that curve that I showed you, with the therapy, we expect that the comfort level should be flatlined through the night and there should be no reason to move your feet. So you can actually both fall and stay asleep. In early testing, we were able to find that a 38% increase in peak blood flow velocity in the periphery was obtained with just 3 minutes of therapy, and these effects were sustained for up to 10 minutes. And the most important part is this therapy is completely subthreshold, which means it's barely perceptible, something you can wear and sleep with. This would be the first responsive therapeutic medical device that addresses this population. We believe we have very strong and defensible IP, and most important of all, we have a very engaged and accessible patient population that truly wants better options than Parkinson's meds. So if we go back to that patient population that I alluded to earlier, 14 million and 8 million adults have moderate to severe RLS, out of which 20% and 80% respectively will seek care. That's 10 million patients that go to a doctor. Half of these end up on therapy, which is what I addressed earlier, and spend close to $4 billion a year just on prescription meds. These are just direct costs out of their pocket. We believe that tapping into even a small subset of this population by providing them with a wearable reversible medical device connected to an application that both tracks outcomes and also compliance allows us to get into this market with still a significant opportunity north of $500 million. We believe that initially our go-to plan would be to go to a specialist's office and sell devices at prescription cost to then leverage that data to go to a private payer for expanded coverage. In the short term, what we're looking for is to iterate our prototype design and engage key opinion leaders both at Stanford's Movement Disorders Lab and outside in the Bay Area to enroll patients in a pilot human IRB study to get concrete results from RLS patients. And finally, none of this would be possible without a team. My co-founder, Mike Llewellyn, is an interventional radiologist by training, and I'm a medical device engineer with over 10 years of circuit design and algorithm development experience. We both met at the Biodesign Fellowship, and we're pretty excited about taking this need to market, and we believe that we have both the skill set and the experience to do that. Thank you.
Judges?
So I saw a price point of like $250 to $400, and that's out of pocket, or?
So that's a good question. The $250 to $400 is their current out-of-pocket costs for what they're paying for their prescriptions over the course of a year. So our early adopter strategy, a thought that we're discussing with our business mentors here, is to go out at the $250 to $400 cost price for maintaining the technology backend, which is the subscription-based device that tracks progress and compliance. And that allows us to generate data to go to a private payer for expanded coverage. But it's certainly not the price point that we've decided to put the device itself at.
So just to be clear, as far as who do you see paying early on? You see the consumer or the payer paying early on?
Consumer directly. So we're going to the specialist's office, in this case a neurologist and a movement disorders physician, and we're working with patients that are early adopters that want alternate therapies outside of opiates and benzodiazepines.
Have you done testing to figure out what % are willing to pay, how much they're willing to pay?
Right, so we've spoken to a total of about 15 patients so far, and that's why I was trying to highlight that this patient population, unlike many other that I've seen, are very engaged, and they have forums online to where they constantly are looking for alternate therapeutic solutions, and you know, they're exploring opportunities including the spectrum like medical marijuana, opiates, acupressure. So this is a patient population that was willing to travel and be part of our pilot studies to see if they can actually benefit from something like this. So the 50% of the patients that I showed you that walk away from therapy is mostly because they read about the side effects of Parkinsonian drugs thrown on these patients, and they say, that's okay, I can just knock myself out to sleep, I'm not going to take those. So we believe that accessing those patients is going to be pretty convincingly easy if we can have a therapeutic that has proven efficacy.
Can you just clarify the clinical outcome you would think you're getting with when the wearable?
Sure. So there's two things we want to track. Number one is the pharmaceutical drugs go for what's known as an IRLS score, It is a 12-point questionnaire which assesses their quality of life. We want to combine the IRLS score, which we think is the clinical standard, although, as you might know, surveys can be subjective. We want to track it. The benefit of having the device be wearable at night is we can also track the number of times they wake up, the number of times they actually move their feet, and the number of times, the number of hours spent sleeping. So by leveraging existing algorithms that do that, we want to use those 3 metrics as evidence of how well our therapy works. And our metric is going to be the time that it takes for you to go to bed or go to sleep.
What's your FDA strategy?
So currently, this would be a non-significant risk device, but we certainly do want it to be a regulated, approved medical device. So a predicate would be a wearable TENS kind of a device, which is a stimulator. We have a stimulation pattern that's a little proprietary and different, so it would require us, in the absence of a direct predicate, it would require us to have some clinical data, demonstration of clinical data. So we believe at worst, it's going to be a de novo pathway to where we do a non-significant risk 510K with clinical efficacy data. And to prefix this, the drug trials, roperidol and pramiprazole, when they submitted to FDA, used 40 patients and 4 weeks of data to get a PMA through. So we believe we're going to be...
The barriers to entry, there's a lot of companies that do neuromodulation. What can you get that's different?
Correct. So, so this is one of the few spaces where there are zero medical devices out there to treat this condition. So one of the main reasons is it is a very complex condition. It is, so deep brain stimulators are the only alternate to this device when it comes to treating RLS, because deep brain stimulators work pretty well for essential tremor, dystonia, and spasticity for patients with Parkinsonian symptoms. But it's excessively invasive for patients that have RLS, because that's an open brain surgery and $70,000.
Do you have any plan to do FDA pre-submission to increase your chance to get FDA feedback? Because
Correct.
It's
so we have a
brand new-
consultant on board through that we got in touch with through the Biodesign Fellowship that is advising us on the IRB that I spoke about earlier. We're lining up the endpoints of the IRB to match what our FDA pre-submission is going to look like.
Awesome. I'm excited because I'm pre-genetically disposed to.
Well, thank you, sir.
Thank you. Well done. Okay, I'd love to welcome out to our second, if we can get the door open, our second company, Corellia Biosystems. Here's your timer. 5 minutes.
Thank you. So my name is Kwesi Apori. I'm here today to tell you about Corellia Biosystems and what we're developing. We're a startup company out of UC Berkeley developing a next generation hepatitis C diagnostic at the point of care. And this is something that's really going to save lives. So our company to date, we've raised $650,000 in grant funding, which we've used to develop our prototype, and we're now seeking to raise our first seed round. So many people here in the room are baby boomers, or you know baby boomers. So your physician has probably told you about hepatitis C, which is a debilitating liver disease that's chronic and can eventually lead to death. 170 million people worldwide suffer from hepatitis C, including 3 million people here in the US alone. And as this poster I'm showing up here is showing, the CDC recommends that every baby boomer born between 1945 and 1965 gets tested for hepatitis C. And why is this? There's 3 reasons. First reason is which 75% of all people who are positive for hepatitis C are baby boomers. The second reason is because you don't show symptoms. The disease can lay latent in your body until a much later date. So there's no way you'd know you have the disease until you get tested. And then the third, and probably the most important reason, is the fact that there have recently been new drugs developed that can actually cure hepatitis C and not just treat the chronic symptoms. So that makes getting widespread screening programs implemented a very important task. But how can you get screening implemented? Not using the current diagnostic tools, and that's because the current diagnostics, there are no point-of-care tests that can detect active viral infection. And if you think about the numbers that I just mentioned of how many people have hep C worldwide, we're going to need to run about 1 billion tests to detect all of the people who are positive for the disease. And not all of these tests are going to happen in your typical Quest Diagnostics or LabCorp clinical labs where you send your samples and get your results back days or weeks later, we're going to need to start testing people at doctors' offices, in hospitals, at free clinics, community health centers, outreach and screening programs. So it's really critical to start doing this at the point of care. And that's why we're introducing our Simple Scan testing platform, which is an instrument that can do your test as simple and as quickly as a lateral flow test, things you think of like your common pregnancy test, but give you actual detection of the virus in quantitation like you would by sending your sample to a lab for a much more sophisticated test. And this platform consists of a consumable chip about the size of a postage stamp, onto which you load a drop of blood and then put your chip into a reader that's battery operated and powered by either your doctor, nurse, or a trained healthcare worker, and to get your result in 15 minutes at about a cost of $10 per run. So this technology platform we're developing is useful for many infectious diseases beyond hepatitis C. And it's going to take about 4 years from where we are now to get FDA approval and into this point of care and clinical diagnostic market with Hep C. So we went out and did a little bit of customer discovery through the Lean Launchpad program, talking to over 150 potential channel partners and customers, and we realized many people also wanted to use this tool as a research instrument, particularly in the pharma industry, to replace cumbersome, manual, labor-intensive tools that are out there right now. So our first served entry addressable market, or our entry market, is going to be this $1.4 billion tools market prior to getting our FDA approval. And what really makes us unique in this tools market is our ability to address the larger portion of the market that the competitors are missing with their focuses on the niche areas. And so when I say the larger portion of the market, this means a part of the market where people want automated tools that can run very quickly on a portable platform at the bedside. And so selling into this market, we're projecting about $135 million in revenue by year 5, doing a razor blade model where the majority of our revenue comes from selling the consumable chips. And so we have intellectual property developed this technology at UC Berkeley, and the secret sauce of what makes this better than the current tools is basically we're doing our binding of our target markers in 3D instead of 2D. And so this lets us go from these slow 3-hour kind of fishing with a pole technique to using our 3D hydrogel network, which allows us to fish with a net to quickly catch the proteins in 15 minutes. The team consists of myself, Kirsten Ross, Sam Tia. We're all here at the conference and happy to talk to you more, so thank you.
Nice.
This is developed. The chip is working now.
So yes, we have a working prototype. So we started a company with NIH funding. We developed this technology as postdocs at UC Berkeley. So we've got about 4 to 5 years of development into this technology, and we're running a prototype system in our lab, but we need to go from a laboratory prototype to something that's validated in a much more stringent fashion to get to our actual approved diagnostic usage.
And then what is the next 4 diagnostics you would do with the technology?
Oh, that's a really great question. And so one really useful thing about our technology is that it can be done at low cost and portable. So one area we have a lot of interest in is sickle cell disease diagnosis. We also have a grant in this area, and we've done some work in West Africa in particular, validating this technology. Another area is, as I mentioned, actually using it as a research tool. So that's something we can actually do before we get to FDA approval. So at year 1, once we validate this internally, we can actually sell this into the pharmaceutical research market, where they're going to use this to replace these common plate-based assays that take 3 to 4 hours. These plate-based assays called ELISAs and protein microarrays, and they can use this multiplex technology in that area. So those are 2 of the things that are on the near horizon for us.
So what's the target population? You mentioned a pretty broad swath of population. What's your real target population to be able to convince payers and providers that this group really needs to be screened? And what's do you expect your hit rate to be on a screening?
That's a great question. And so we actually, the CDC's done some of that work for us. We don't need to convince, people that they need to be screened for hepatitis C, because the CDC has put out this call for screening all baby boomers, so people born between 1945 and 1965, and that's because hepatitis C was not screened in blood products prior to 1992, and that's what makes this population so susceptible. And people are 5 times more likely if they're a baby boomer to have hep C. So that's really the target population for the technology.
With the qualification that they've had a blood transfusion, or just the whole population?
It's not only transmitted by blood transfusions, but that's part of the reason why the incidence is so high in the baby boomer population. So the CDC is actually recommending that all baby boomers are tested. And that's why when I say 1 billion tests need to be run worldwide, you can think of the baby boomer population and the fact that you're probably going to test about 10 people for every 1 person that's positive that you catch. And so there are a lot of tests that need to be run in the global market for hepatitis C.
Any other questions? We got it? All right, great. Well done.
Thanks.
Our next company is Lighthouse. I'd like to call Dave out. All right, 5 minutes.
In the 10 minutes we're about to spend together talking about startups and traction and MVPs, 2 people in the United States will die of diabetes-related disease. 1 person will lose a limb. 35 people will hear for the first time that they have diabetes, and 2 out of 3 of them will eventually have a heart attack and die. The numbers just keep going up. What we hear from patients is that my doctor is great at telling me what to do, and she is terrible at telling me how to do it. We are asking our loved ones to age in place and not giving them the tools to not head towards acute care. We need heroes to rise up and change how the health is delivered. We need doctors to deliver more expanded programs, nurses and educators to connect with people who need the help, and volunteers to do that great stuff that volunteers do. I'm Dave Vockel, CEO of Lighthouse, and we are in the business of making heroes and getting them paid. We do it in partnership with the American Diabetes Association, our biggest investor. They vet all of our patient and doctor-facing programs, have already connected us with some of their biggest corporate partners, and they have 150,000 rabid volunteers waiting to be our evangelists. At the heart of our offering is a coordinated care platform that integrates into every major EMR and helps the doctor identify opportunities for care, connected to a digital patient program that is somewhere between a boot camp in chronic disease and a graduate program in self-care. Combined with our wildly compassionate team of nurses and diabetes educators and counselors, we qualify doctors for a Medicare incentive of $500 per patient per year. We get them paid. If you're an educator, a nurse, and you want to help, join us. If you've got 15 minutes or 3 hours, log in. We will connect you to someone who needs care, and we will pay you. Spend 100 hours with us and do a little training, and you're on your way to getting the first diabetes telecare certification. If your heart brings you to this group, please connect with us, and we will give you a territory, materials, and a mission to help us change the quality of care that gets delivered. We went from pilots to first general rollout March 1st. Handful of practices, about 3,600 addressable patients. Last week at the American Diabetes Scientific Sessions, they announced a partnership with Watson to delve into diabetes. We are the tip of that sword, which is why our conference room looks like this week after the activity we've had in the past 7 days. Our team, if you meet our team, they are wildly compassionate about the health of total strangers and wildly accomplished in their past. Except for the CTO, who we let go last week for culture problems. Startups are made and broken on the hard choices they make. We've brought on our original CTO, who's got great startup experience. He's very good looking. My wife loves him, but he's not the right person for that long-term spot. We talk a lot about diabetes because they're our big partner. We also deliver against other chronic conditions. Among our competitive set, the two big differentiators are we are much more active in driving forward the health plans of the patients, and we've got this wildly unfair advantage of name recognition equal to everybody else put together. We're Lighthouse. We're in the business of making heroes. Pull out your phone, text "Be a Hero" to 313131, and join us in changing the quality of care delivered to our aging population.
Well done. Judges?
So why did the ADA pick you, and what do you have that's different in terms of your services and products than some of the other competitors?
Internally, the summary is, I hustled the shit out of them.
Happy and hungry.
The conversation went a lot like, you guys are a great 1970s charity. You schedule bike-a-thons with the best of them. Last year at your scientific sessions, there was not one digital session. And I'm pretty sure in 2015, someone is using a computer or a phone to manage their health. I said, in 5 years, you could be the #1 deliverer of care to people living with diabetes in the United States, and you could lurch forward the knowledge of digital plus patient plus nurse and how they all go together. What we do different than our competitive set is most of them are focused on great data syndication and light meds reconciliation. Do you know what's going on? We deliberately work against the care plans, and each month someone different calls you to advance your diet, physical activity, adherence, and kind of hustle it forward that way. We're also more startup-y than the rest in that our competitors are already starting to strain under scale because they're nursing services that have tried to do this new thing. We think about scale and delivery all the time and how we make this a great business.
So I think the problem, the need, they're all very self-evident and huge problems, right? I think the piece I was curious about is who do you see your customer base as, and when you talk about reimbursement, how do you see that working? I think you cited a $500 fee relative to providers on an annual basis. Could you talk about what that looks like in terms of revenue model?
So the majority of care to chronic care patients is delivered by family doctors. That's who sees them the most. We integrate into their EMR, but if you're not in the patient flow, you're never going to be part of the solution they deliver. We've just completed our 3rd cycle of Medicare billing against CMS 99490, which is between $42 and $50 per patient per month. So we initially are selling into independent family practices because that particular physician is in charge of the care that gets delivered in their office, and they get to keep the money. Different than a family doc at Sutter, which neither of those two things are true.
Sorry, real quick on that. So with the CCM code, are you actually delivering the 20 minutes of non-face-to-face service per month, or are you giving them a platform to enable them and their care team to deliver it?
Only the worst people doing this give them the platform for them to do it themselves. Sutter Sutter already tried this program, delivering it themselves, and it broke in 2 months because of it's a change in workflow. The economics of a nurse living in the Silicon Valley is busted. All of our nurses are distributed across the country, and they can participate with us 15 minutes a week or 10 hours a week. They log on their own schedule, and we here's who needs care today, hit the button, and the phone call takes place. So we do tracking nurse, we're the nurse service, yeah.
So you're the outsourced service. So of the 42 a month, of which there's a 20% copay, how much do you guys keep, and what economics does the practice? I'm order of magnitude. I'm not looking to put you on the spot in terms of
put me on the spot.
Pricing.
Yeah, so if it's $42, we get 20, they get the rest.
Got it.
And there's a copay. About 85% of patients, it's covered by a supplementary insurance. But you have excellent detail on the problem.
So for the individual who's using this, how do we know what sustained health outcomes over time?
So the good thing about most chronic diseases is if we understand how much you're taking your meds, how physically active you are, and some insight into your diet, there's many studies which can play very far forward what the health outcome is going to be. So we don't have to wait 7 years to see if it works or not. If we can demonstrate that we've taken this person from 10 minutes of physical activity to 45, carbs from A to B, and adherence at a certain level, much sooner we'll be able to see, does it work? We have to assume,
And we're done.
we have to assume the incentive is going away, and we have to prove that it works.
Awesome.
All right,
Great. Excellent. Our next company is Holistic Health.
Yeah, hi, my name is Bo Beck. I'm Vice President of Marketing and Business Development for Holistic Labs. And we, oops, backwards. We're getting there. So our company was founded 4 years ago and has a very strong background in networking technologies across wireless space, cellular space, and so forth. The team has worked together at both small startups as well as large companies. The problem that we're looking at is well known. The number of people aging and facing the choice of moving into assisted care is growing dramatically. There's a lack of facilities as well as often personal savings to pay for those facilities nor a desire to move into those facilities in any case. And so, facilitating the ability of people to age in place in their homes is a critical need. Now, there's technology being applied, fall detection, all kinds of safety systems and so forth, and that's great and that's necessary. But once that gets installed, someone needs to make sure that that stays up and running, or the whole premise of allowing them to age in place sort of falls short. So that's what the technology we've developed is about, is to really a technical support solution that it enables the essential systems to enable a person to age in place, make sure that they're continuously operational and efficiently supported. The company has a couple key pillars. The first is some very deep technology that works in the user home, working in conjunction with the cloud, that enables the profiling of the entire home on an automatic basis to understand every connected device in the home and the health of that device. It enables us to bridge between the person seeking help, their loved ones, as well as the professionals, so that there is support needed, where needed, when needed for those people, so that they get efficient and capable help when they need it. And then lastly, by really looking at the whole process by which someone might decide to make an investment in technology that allows them to age in place. That includes the selection of the technology, selection of an installer who's capable of making that installation happen, financing of that, the support for that long term, as well as working with insurance companies on compensation mechanisms. And the whole platform is a learning platform that really automatically profiles this digital home and really works at taking the guesswork out of the technical support that we all experience. Whoa. Sorry. Okay. At the core, there's a cloud. There's also application that sits in the end user premise, and it can run on an Apple, iOS device, a Mac, Android, PC, or Linux box. And that application, as downloadable, just probes the network at many different layers and helps us to fingerprint each and every device on the network. And that allows us to create a map of all those connected devices, understand the connectivity, Wi-Fi, the ISP, all of the inner home connectivity and all the sensor systems that are existent in the home, and then give tools so that that user can, through their application, actually reach out through embedded sort of voice, video, chat collaboration and get the help they need. We have a knowledge base of basically all of the world's sort of products that are out there, including the metadata around FAQs, and we match them to the devices in the home so that the caregivers can easily understand what to do and how to help keep these systems up and running. And there's a portal for the caregivers to be able to remotely see into the end users' networks when they call looking for support. And even so much as to turn on the video on their phone and actually stream an image of the device in question or the thing that's not working and so forth. So again, the idea is to avoid truck rolls, which are the most expensive form of technical support there is, and to, wherever possible, make that a remote support experience. There are many different categories of technology that could comprise an aging in place a solution, but with all of these, we can profile and identify all of these devices, and we help with the different connectivity elements of it, remotely monitor these systems, and also enable loved ones to kind of patch in to get the help they need for their loved ones. On the service side, we really enable the service provider, instead of the experience that we all have today when we call anyone for support. You play 20 questions. You answer all very simple questions about what do you have in your home? Is it on? Have you power cycled it? All kinds of dumb questions. Well, in this case, when that caregiver comes online with the user, they immediately see the full context of everything that's going on in the home. So right there, the duration of the call is dramatically shortened, and then they can actually proactively help that person and even have alarms and things so that the user doesn't have to do anything themselves. We can actually have it set so that when a system goes down, we're already at 5 minutes?
Yeah.
Jeez.
Sorry, it's fast, isn't it?
That was fast.
It does go fast. All right, judges, ask him the rest of the questions from his presentation, and we'll all be happy.
What are your core customer acquisition economics and LTV look like?
Yeah, so what we're looking to do is to work as a B2B to C kind of a play. We're looking at distribution partnerships. We've identified several different groups, some of which we're already working in. We've deployed in pilots with the whole CE Pro installer base. There's about 100,000 of these guys, and they serve a variety of people from the high-end sort of home automation markets, but increasingly helping with the aging in place market. So that's one area where we quickly are going to roll out our service. We charge on a monthly recurring basis, and the profitability by the end of the first year is in the gross margin in the 70-80% range. So it's really our core costs are just developing those partnerships and getting the distribution into their their user bases.
It seems to me that your solution assumes that there's been considerable penetration of direct-to-consumer aging-in-place technology, and that then once it's in the home, the lack of interoperability and things like that poses a technology challenge that you can come in and diagnose. Am I reading that
well,
right?
actually, in the case of the aging-in-place market, we're really viewing it as a huge need that has not yet been adequately addressed. So there's lots of technology available independently of each other. What we feel that is needed to catalyze the market is to be able to approach someone with a package that says, this is all the systems you need, this is the cost, you can finance it, and get in and have a long-term support so you can sort of age in peace. You don't have to worry about keeping these systems up and running. So the key is to package it together in a way that's easy to say yes, no, and my alternative is some much more expensive version of care or moving them out of their home altogether. So from an ROI perspective,
So you become a channel for the sale of aging-in-place tech?
We're a platform, and we use our distribution partners who are, could be housing developments, home development companies, professional installers, aging in place organizations, and so forth to reach those users.
Gavin, you've got to have a question. Come on.
I was actually just about to ask. Would love to get your thoughts on why this market, aging in place, consumer-friendly technology, has taken longer to kind of live up to its promise of fulfillment, kind of to follow on to Jody's question.
Well, I mean, we look at it, we think of two key barriers. One is sort of the cost of the technology and the maturity of that technology. And the other is the ability to just know that it's going to be there when you need it. And we feel like, the work that the team has done totally addresses that second column. And then we worked on partnerships with personal loan companies. So literally, you could literally apply for a loan in line in the application and get an instant response back and say, I pick an installer, I get a $5,000-$10,000 loan. They come out, they do it. You can basically do it all. So we're trying to make it so that the process itself is much easier for people to say yes and to find the solution they need, as opposed to having to go and educate themselves and piece together a system on their own, without any tools at their disposal.
Could you, relative to adoption challenges, which I'm definitely on the same page with Jody on, is could you speak to your install base so far and what that's looked like through your existing distribution channels?
Yeah, so the technology, we just went into pilot last month. So we're just rolling it out to selected sort of CE professionals, and they are evaluating it and starting to deploy it into some of their sites and locations. We look at the AIP market as a key market to penetrate, but we have not yet established the partnerships yet to do so. So that's one of the reasons we're here.
Anything else? No? Great. Well done. Our next company is Dynamic Health. You need this.
I do. Forward is forward?
Yeah.
All right. Hello, my name is Michael Karsha. I'm with Dynamic Health, and I'm going to be telling you about how we are working towards improving the quality of life of those living with underactive bladder. So this is Nancy. She's an active 65-year-old who has an underactive bladder. So living with an underactive bladder means that when you go to the bathroom, you can only generate a trickle, and after you go to the bathroom, your bladder is still relatively full. So over time, this leads to issues of urinary frequency, incontinence, chronic urinary tract infections. And Nancy's not alone. There's 4 million women in the United States living with symptoms of underactive bladder. As her symptoms begin to get worse, she'll eventually seek care, and she'll soon find out that medicine really has no good solutions for her. At some point, she'll be prescribed intermittent catheterization, which is barely visible there, but is the act of taking a rigid catheter, locating your urethra, inserting this device every time you'd like to use the bathroom 4 to 6 times per day. Over time, as you can imagine, as Nancy ages, this will become increasingly difficult. Her eyesight will become worse, dexterity becomes worse, et cetera. And in fact, in the United States today, only about 100,000 women are catheterizing. And two out of 3 women who are prescribed catheterization either stop using it almost immediately or eventually. This still represents a market of about $300 million, and we think we can do better as far as the solution goes. So let's go back to what those solutions that are out there. So we talked about intermittent catheterization. There's also medication, although these actually really don't work very well. And another solution that has existed is a device called VesiFlow, which I'll mention briefly here. This was a device that came out about 10 or so years ago, 20 years ago. It's a motor-driven urethral prosthesis. The patient has a remote control. The remote control activates a motor and allows the patient to empty their bladder. When patients heard about this, they actually initially liked it, the concept of it, but quickly found out that it was very uncomfortable to have this rigid device in your urethra. The device actually leaked, and so patients who were continent were becoming incontinent. The device was very loud. One patient referred to it as activating a power drill in a bathroom. And in fact, actually in VesiFlow's own pivotal study, 50% of patients terminate using the device after 1 week. So there's still, we believe, a very sizable opportunity here, and to date, actually, VesiFlow has really had no market adoption. But they did show one important piece of science that caught our attention, which is that you can insert a device into the urethra for up to a month and not have additional risk of urinary tract infections as compared to intermittent catheterization. So we saw this insight and motivated to do better, designed the Katie dynamic catheter. So Katie is a catheter that sits in the urethra in between the bladder and the urethral opening. And if you think about the same way an artificial leg will help an amputee to walk, the Katie will allow a woman with underactive bladder to completely void. So the device is initially placed by a physician. It enables normal seated physiologic voiding, and the device will eventually be removed and replaced every 29 days by the patient themselves. So here's an early prototype of the Katie. You can see it's a very soft device. It will be squeezed closed by sphincter pressure, and this will enable the comfort aspect of it. And it works by shifting the pressure flow curve of the urethra. So the Katie can take a woman who is generating some amount of trickle and give her a full stream, as well as a woman in retention and allow her to completely void her bladder. So we built a test bench to prove this concept out. This is actual data of the Katie working on that test bench, showing both the shift in the curve and that we can form a watertight seal. And so thinking about value proposition, there's sort of two patient populations to think about. There's the more active woman who really were trying to improve compliance, and it's sort of all about convenience. So with the Katie device, we're minimizing the amount of time spent catheterizing. They don't need to carry around supplies. If you're going on a vacation, you don't need to carry around 100 different catheters with you for a week. And the idea and the aim is to reduce the rate of complication and improve adherence. For an older patient, perhaps living in assisted living, many of those still concepts apply, although it's really more about the caretaker burden. So this device is non-surgical, which is good, but it really enables independence this is no longer advancing, for the patient. One more slide, all right. Well, so we can get to the rest of this maybe over questions, but our next steps are more about clinical feasibility. We're setting up a trial at Stanford to test that. All right, thank you.
Judges? Self-catheter.
One at a time now.
Sorry.
Could you talk a little bit about clinical feasibility, please?
Sure.
I don't know this gentleman, by the way.
So, back to the beginning. Okay. So the big question is really around, will the device work, which we believe it will, as per the test bench data, but more importantly about comfort, being that that's the biggest reason that patients are not using the device. So initially, we're doing short-term feasibility studies as far as inserting the device, sort of inquiring with the patient, is it comfortable, sort of more of a one-day sort of trial per patient. That'll be during the sort of seed phase, and then longer term, we believe this is a 510K device, and so we will be collecting a sort of a longer term trial, which will prove out data around infection rates and will there be erosion and sort of other questions that come up, which we believe won't be the case.
Would the intent be that it would be reimbursed by Medicare and payers?
So the intent is reimbursement by Medicare. That there is we would need to seek a code. Which is sort of a later slide. No, it's not.
I don't know if I'm comfortable with that slide advance.
Okay, yeah, I'm not either. Oh, I thought we could do that during the interview. Oh, okay. Well, at any rate. Sorry, this has a mind of its own. I'm not doing this at all here. I really am not doing it.
This is a good entrepreneur right here.
I forgot the question now after all this. But.
Reimbursement?
Oh yeah, reimbursement. So we will be seeking a code. There's no code that we would want to fall under. We do believe that the VESTAFLOW device will actually provide a code soon, and we would which would be applicable towards us. We're targeting a price point similar to a year of intermittent catheterization. But that said, there's still sort of a self-pay option for if the device works the way we believe it should.
Scott, did you have a question?
So you have not put this in patients yet?
Correct.
So you don't know, you haven't really shown that the self-catheterization is going to be possible?
Well, self-catheterization being what is currently patients are doing today. They're inserting catheters into their body. And the way that insertion of our device would work is with a sort of a handheld insertion device. The VESTAFLOW device kind of works on a similar concept. And so we believe that's very doable. Yeah.
What does the procedure look like every 29 days for the patient in terms of they have to go into the office? I mean, how quick, how painless, how easy is that?
So the first visit, or the first insertion will be at the physician's office. There'll be sort of a sizing procedure that'll be done to make sure that the diameter and length is appropriate. Beyond that, the patient will insert it on their own. The process would be very similar to how they would have inserted an intermittent catheter, but instead of doing it 5 or 6 times a day, they would do it once a month with this disposable applicator. Yes.
So that 125 million revenue is per what?
So that is our year 7 target on a $300 million market, not expanding, assuming we don't expand the market.
Okay. And the exits in the industry have been, that's what that's referring to?
Correct, and these are listed down bottom. Liberator Medical for $180 million in Rochester Medical 260.
Speak to the existing RX therapy, and it was kind of described as ineffective. What is that, and do you see any other pharmaceuticals coming out that could be an effective competitor?
There hasn't been actually any innovation in this space. Underactive bladder is somewhat a forgotten space of urology. There's a lot of people talking about overactive bladder, but not underactive bladder. The medications I mentioned are very old traditional medications, alpha-1 agonists, for instance. So there really hasn't been any innovation in this space, and we don't see any innovation coming in the near future.
That wasn't my comment. I got a couple more seconds.
Okay. I wasn't doing anything.
Any other questions?
How do you plan to address, this device itself is very, because you haven't done any trial yet, right? So how do you plan to make sure this device, the design of the device is going to be very user-friendly, especially dealing with this, like how do you even start with that? Are you working with some organizations, doctors to refine the design to be your first prototype? Or?
So the device to date, we've tested on the bench. We've also tested it in bovine cadaver. The part of that first trial will be around comfort, but also around applicator insertion, and there's sort of a usability component. So that's sort of this first entree we're doing is to mitigate sort of the easy risks and especially the most important one, which we think is comfort and quality and actual use.
Got it. Great.
All right, thank you very much.
And our final company, does everybody still have some energy? A little bit? Judges, you still awake? All of you all look awake. All right. Is Mavie.
Hi, everyone. My name is Heidi Culbertson, and I'm the CEO and co-founder of Marvi. Marvi is a concierge solution that assists those that are hindered by vision, limited mobility, or just typical aging challenges, a way to communicate with family and caregivers. It's really a quality of life solution that addresses the 44 million caregivers that are running around today taking care of elder parents and loved ones. Quick note about our team. I've spent the last 20 years following the adoption curve of mobile in the mobile industry. My co-founder is a serial entrepreneur and an angel investor. The team comes from mobile software and IoT, and a special team member is my mother. My mother's name is Marvi. She's 94 years old, and several years ago she began to lose her vision due to macular degeneration, which is common eye disease among the aging. And today she's completely blind. So many simple things have become impossible or just difficult because that first action is out of reach. You know, feeling for the speed dial button to make a call and often misdialing, which she did this morning. It's very much affected her independence and her isolation, and it's caused a lot more running around for my family. Now, a year and a half ago, we gave my mother an Amazon Echo, really for personal entertainment reasons. Absolutely loves it and started asking if it could do certain things. There are these little nuances that are specific to this age group, specific to anyone with physical limitations, and specific to family caregivers that a touchless solution for the senior adult and a centralized control for the family caregiver can solve. So how does Marvi work? The user speaks a request, That request is recognized, Marvy matches it to a contact, and that contact receives an instant notification. Now, we've built Marvy to be specifically designed for both a senior adult or a family caregiver. You set up the service, you add your contacts, and that's it. We're in pre-launch, but very soon we'll be launching beta with 4 services, and they're both notification and engagement type services. You know, setting an I'm okay message. Now, family news was the one that I'm from a very large family. My mother wanted family news. Family news allows family members to input updates on just life, what's going on in their life, and those updates are read back to the user upon their request. I actually have an Echo set up, which I can demo later, because I don't want to use up all of my 5 minutes making sure it's connected to Wi-Fi. But if my mom was to say, you know, ask Marvy for family news, she would have heard me say, I'm in California, I'm at the Boomer Summit, I'll call you later. So it really is about engagement. So our business model is a subscription model. Tiered pricing, cross-sell, upsell opportunity, white label opportunity. We are a solution that will ride on top of other hardware and voice service platforms beyond the Amazon Echo. We're very excited when Google announced Google Home. Apple's opening up the APIs to Siri. So we plan on running on top of all of those. Marvy meets a lot of populations where they are. And we're focused on business growth. We envision being profitable in year 2, and we are seeking investment to accelerate execution and growth. So how are we going to go to market? It's really about scaling through 3 primary channels: direct to the consumer, through Marvy, through the Amazon Alexa catalog, Google and Apple once they launch. We'll partner with large organizations that have large membership bases so that Marvy can be offered as one of their pool of offerings. And we'll partner with product and service providers, smart homes, healthcare entities. Had a conversation with one of the top speakers at QVC on electronics, and that's an older demographic, and he wanted some ideas on what the Alexa skills were for that. So there's lots of opportunity. I believe, the whole team believes, that we have a very collaborative market landscape in caregiving. Marvy will be able to integrate. Marvy will be able to really offer extension to other care and longevity focused providers. And we have the opportunity to affect family care.
Great.
I step back next to you. Questions? I have answers, probably, hopefully.
What's the adoption of Echo in kind of the target demographic, or any kind of data from Amazon, Google, Apple on kind of where they think, because it sounds like that's a prerequisite for the service, so curious how many units are out there.
Yeah, that's a great question. Amazon is not naturally known for releasing their numbers. I know in December that they said, you know, in that year they had sold just over 3 million, and most of those were sold at Christmas time. Alexa, which is really the voice service, is now being implemented on different types of devices. For example, the Tribby is a kitchen appliance, and that's the first non-Amazon device that's come out. I think the success of this has forced Google and Apple to accelerate their personal assistant initiatives. And I also believe that if you look at any of the comments and the blogs and the reviews, there's a very high percentage of people my age, anyone who has a grandparent, where it's, you know, can we get reminders for taking your medicine? It's all about elder parents. So I think those voices are being heard, but it's hard to say hard numbers because they're not being released yet.
And what's to prevent some of those players from just doing their own program when they get around to it, if this is successful, and sort of usurping your marketplace when you need them, but they don't necessarily need you?
Yeah, that's a great question. I think if Amazon or Google were to try and do a caregiving, I think that would be wonderful. actually. First, it improves the market. And second, their main goal is to have people buy Amazon products through the Alexa voice service. So we just have to be better at the caregiving niche and addressing the very unique needs of this group to really win the high-value customers. So I think that's actually a positive thing, and I think it will actually accelerate innovation.
Jody, you've been talking about Echo all day.
Yeah, so.
I know, and you see it down here,
Yeah,
too.
I do see it. I do see it. In fact, that's why I raised it earlier. So what I'm wondering about is, are you simply too early?
I don't think so. I think that, and that's a great question. I've spent the last 20 years in mobile, where no one had a cell phone, and then it was GPS and things like that. There's two audiences here. There's the senior adult, and there's the family caregiver. If I was to ask the audience how many of you have ever accessed GPS with your voice in your car on your phone, it would be a high percentage. I think the adoption of voice activation is already happening, and I think the success of the device, we'll see an increase in that, and I think we're going to see different form factors that affect affordability. But I think we're in that education phase. We just recently moved my mother into assisted living for social reasons more than anything. And half of her assisted living facility has now bought Echoes because my mother uses it. So I think it's really about just recognition and evangelizing.
Okay, we have time for one more. Any more questions?
How do you think about getting all the participants to sort of partake in this system? Certainly there's going to be an adult child who perhaps purchases this.
Yeah.
And then they have to get the parent, to use this. And then certainly that adult child and other family members would have to input content into this platform. How do you think about, getting that to proliferate throughout that local network?
Yeah, I mean, a lot of times,
And let me just say as a point of reference, when Lively was created, the whole idea with their Livelygram was that the family would play this active role.
Right.
Unfortunately, families don't.
Right. Well, and there's a wide spectrum here. I mean, I've got an older parent who's in her 90s, and my mother was an active tennis player until she was in her late 80s. And she said, I would have used this when I had both my knees replaced and my rotator cuff surgery, even for a short term. So there's a lot of different audiences. When we gave it to my mother, when it first came out, she can't see the circle at the top that has the light, whether it hears you. So we had to teach her to pause 2 minutes, and I'll back up because it's the ringer.
Well done.
Thank you. Oh, where's the door?
You don't
This
get to go
one.
back. So as I mentioned, we're going to take the judges into a room. They're going to battle it out. The announcement will be at the end of the day, and we'll give away the big, huge check to the company that was selected. I believe right now we have a short break, networking break, and we'll see you back here soon. Thanks.